Okay, we're back, and now we're going to talk about the evaluation and treatment of our osteomyelitis or our bone infection. Obviously, our lab data is going to definitely show a much elevated white blood count. It should be very, very high, way over 10,000. Our x-rays might show that Brody's abscesses, but they will do bone scanning, computed tomography, MRI scanning with the gadolinium contrast shows both bone and soft tissue, can show an infection. Treatment, antibiotics. They will include, usually it's a penicillinase resistant penicillin, so much stronger penicillin that we know the antibiotics are not resistant to, such as nafcillin or Nafcil or Bacticil, which is an oxacillin. And they will not only give them, because those are both gram-positive and gram-negative, but they hit gram-positive bacteria hard, they will give them along with an aminoglycoside, which we know are very, very powerful IV antibiotics for gram-negative bacteria, except for neomycin is the one that'll clean the belly out prior to GI surgery. But they will definitely take blood cultures first before they start with one of these very strong penicillinase resistant antibiotics, and then they'll have them on aminoglycosides also. Debridement with a bone biopsy, a lot of times just to see what's going on in the bone. That's why the biopsy, and debride the area, meaning to take some of the pus and exudate out. They can also put a biodegradable antibiotic impregnated beads that are like, they're these little, they look like little gel, beads of gel that have antibiotics in them, and sometimes they'll insert those right into a wound. Chronic conditions may require surgical removal of the inflammatory pus area, followed by continuous wound irrigation, and they have wound vacs on now that continually drain the wound of the garbage. And they may be putting antibiotics directly into the wound, as well as the systemic antibiotics with our aminoglycosides and our penicillinase. Also with treatment, immobilization of the affected body part, usually by a cast, traction, or just bed rest, depending on what the wound is, where it is, and how we can best get to it. Supportive measures such as analgesic for pain and IV fluids to maintain hydration. Okay, that's the end of our osteomyelitis. Now we're going to move on to osteo versus rheumatoid arthritis. In osteoarthritis, it can be very painful, but not near as debilitating as rheumatoid. It's the most common form of arthritis, and it is basically the loss of the articular cartilage. It's as the disease progresses, the surface areas of the articular cartilage flake off, and deeper layers develop what we call longitudinal fissures. It's like an eroding of the articular cartilage. The cartilage becomes thin and may be absent over some areas, leaving the underlying bone unprotected. The unprotected bone becomes sclerotic, dense, and very, very hard. Cysts sometimes develop in the subchondral bone. Pressure builds in the cysts until the cystic contents are forced into the synovial cavity, breaking through the articular cartilage on the way. Articular cartilage at this point is eroding. Cartilage-coated osteophytes may grow outward from the underlying bone and alter the bone contours and basically alter the anatomy of the bone. It even looks different. Okay. Articular cartilage is lost through a cascade of cytokine and anabolic growth factor pathways. Enzymatic processes is what's eroding all of this. Assist in breaking down the macromolecules of proteoglycans, glycoaminoglycans, and collagen into large diffusible fragments. This enzyme destruction of articular cartilage begins in the matrix with destruction of proteoglycans and collagen fibers. Collagen breakdown destroys the fibrils that give articular cartilage its strength and exposes the chondrocytes to mechanical stress and enzyme attack. A cycle of destruction begins that involves all the components of articular cartilage, the proteoglycans, collagen fibers, and chondrocytes. So basically, the enzymatic process are off in osteoarthritis, and it turns into enzymatic destruction. Clinical manifestations is, what does it look like? Is pain in one or more joints aggravated by weight bearing or use of the joint and relieved by resting the joint, so not moving the joint. Nocturnal pain is usually not relieved by rest and may be accompanied by paresthesia, which is a numbing, tingling, or prickling sensation at night. Referred pain, especially in the LS spine, which is the lumbosacral spine, the lower back, may mimic sciatica. Osteoarthritis or OA in the hip may be referred to the thigh or the knees, so it can have referred pain. Sleep deprivation adds to the stress of the chronic pain of OA because they're woken up with this pain. Physical exam, general involvement of both peripheral and central joints. Peripheral joints can be the hands, wrists, knees, and feet. They're out in the periphery. Central is going to be the spine, cervical and lumbosacral spine, shoulders, and hips. So symptoms: pain, stiffness, and tenderness of any of these joints, enlargement and swelling, muscle wasting. It can even be a partial dislocation. They can look deformed. The joints don't look right. And then we have terms such as Herberdens and Bouchard's nodes. And both of these are in the fingers. Herberdens are the ends of the fingers. And there it says bony enlargements of the distal interphalangeal joints. So sometimes it's the one right lower than the nail bed. And those will be very, very prominent and enlarged. And then Bouchard's nodes are the bony enlargements due to the proximal interphalangeal joints. So they're in the middle of the fingers or the toes or towards the end of the fingers. And Herberdin and Bouchard, I'm sure, are the people that founded these bony prominences, outpouching of fingers in osteoarthritis. Evaluation is going to be physical exam. You can see that the joint's inflamed, x-rays, again, CAT scan, arthroscopy, MRI. Again, magnetic resonance imaging for an MRI is a picture by a scanner to look inside the body. CAT scan produces multiple images inside the body, can be a cross-sectional picture of a body. All of these are just diagnostic procedures. Treatment, we're going to rest the involved joint. What else can we do until inflammation subsides? Range of motion, we have to keep it moving somehow between periods of rest so that it doesn't atrophy and contracture forms. Use of cane, crutches, or walker, these are just aids to decrease weight bearing on a joint. Weight loss, if obese, the larger you are, the more pressure you're putting on joints. And analgesics and anti-inflammatory drug of swelling and pain. Treatment for OA, other than analgesics and anti-inflammatory drugs, we've got glucosamine, chondroitin, intra-articular injection of high molecular weight, viscous supplements, particularly hyaluronic acid for knee pain. And then I've got some statistics, and this is from 2015. We had 138,700 hip replacements performed in the year 2000. Of the 310,800 performed in 2010, so 10 years later, we've almost tripled it. 80,000 were 75 years and older. So as the population is aging, we're going to see more and more of this. And 15 was the last time they looked at this. This U.S. National Institute of Arthritis and Musculoskeletal and Skin Diseases does this every 5 years. So next year it'll be a new one part to look at. So something that is going to affect a lot of people. All right, so now we're going to look at rheumatoid arthritis as opposed to osteo, which is basically lost through enzymatic processes. Enzymes break down the loss of proteoglycans. Rheumatoid arthritis is systemic inflammatory. It's an autoimmune disease associated with swelling and pain in multiple joints. First joint tissue to be affected is the synovial membrane, which lines the joint cavity. And that's the difference, where OA is taken down by enzymatic processes and breakdown of proteoglycans, rheumatoid arthritis is the synovial membrane. Inflammation may spread to articular cartilage, the fibrous joint capsule, and surrounding ligaments and tendons. It causes pain, joint deformity, and loss of function, very similar to OA in that respect. Affected parts of the body can be almost anything. And the reason why rheumatoid is just so much more severe is because it also affects the connective tissue of the lungs, heart, kidneys, and skin. Prevalence, much more common in women and affects 1 to 2% of adults. Researchers think because it's more prominent in women that it has a hormonal link because the disease symptoms decrease during pregnancy and then they increase in the postpartum period. So we've got different hormones such as prolactin and progesterone that dominate during pregnancy and not estrogen. So there's that estrogen again, very, very important hormone. Etiology remains obscure. They don't really know. It's a combination of genetic factors interacting with inflammatory mediators. I can tell you this. Rheumatoid arthritis is more of a rapid onset, and there's also a blood test for it. We take a level. The RA factor can actually be drawn in your blood to see if it's present or not. And osteo slowly develops and gradually worsens over time. So it's slower. It's more of an older adult onset. RA can be very young. It can be children. It can be teenagers. Rheumatoid arthritis is all over the body in multiple joints. Osteo can be just a small finger joint or a thumb, as well as knees, and it may just be one joint. Rheumatoid arthritis is symmetric. It's both sides of the body. It does not discriminate. So with rheumatoid arthritis, we have an inflammatory response. We've got neutrophils and other cells in the synovial fluid become activated, degrading the surface layer of the articular cartilage. Cytokines, particularly that TNF factor again, tumor necrosis factor alpha, stimulate synthesis of pro-inflammatory compounds and cause the chondrocytes to attack the cartilage, and hence we have the autoimmune. Why do we have chondrocytes attacking our own cartilage? Nobody knows. Synovium digests nearby cartilage, releasing inflammatory molecules containing the TNF factor alpha. Okay, I'm going to stop right there. We'll continue with the pathophysiology of RA in our last and final video of the day. I'll be right back.